Make the wrong call prescribing an anticoagulant, and the patient faces one of two immediate outcomes. They either bleed out or throw a fatal clot. It's a high-stakes decision, yet medical textbooks bury the answers under pages of overlapping indications. That leaves junior clinicians freezing up at the bedside, unsure of which path to take. To fix this, we need to look at the three main drug classes actually available to you: the old standard, Warfarin, the heparins, which include enoxaparin and unfractionated heparin, and the newer non-vitamin K oral anticoagulants, or NOACs. Selecting the right drug comes down to scenario matching based on the patient's organ function, prioritizing physiology over the age of the medication. Before we build that selection system, we need to clear the field. We are taking aspirin and clopidogrel completely out of this core discussion. These are antiplatelets. They serve a strictly preventative role, meaning they offer absolutely zero therapeutic value when you are trying to treat an active thrombosis. With those set aside, we can map the actual anticoagulants onto this blank three-branch decision tree. This framework is built to make the correct therapeutic choice obvious in under 60 seconds. By abandoning dense textbook layouts for this algorithmic flowchart, you reduce your cognitive load and prevent catastrophic ward errors during high-stress admissions. The first major patient category you will encounter is anyone presenting with valvular heart disease. Look at the first branch. The clinical rule is absolute. Valvular disease mandates the older oral option, Warfarin. Expanding this node reveals its trade-off. Warfarin is incredibly slow-acting, taking 5 days to reach therapeutic efficacy, leaving a massive preventative gap. You cannot leave a patient unprotected for 5 days. To fix this, we use a clinical workaround called bridging. We fill that dangerous gap by co-administering enoxaparin, a low molecular weight heparin, for the first 5 days, protecting the patient until Warfarin takes over. For valvular patients, you sacrifice the convenience of a fast-acting pill for precise control, accepting the heavy clinical burden of managing that inpatient bridge. Our second branch covers high-risk hospital admissions, specifically patients with active cancer or those who are pregnant. These patients require enoxaparin or unfractionated heparin. These IV or subcutaneous options ensure strict, rapid response control while they are admitted. Within these hospital admissions, there is a critical subcategory you must isolate: patients suffering from severe renal failure. The mnemonic UFH equals urine failure serves as a quick reference. When the kidneys are failing, unfractionated heparin is the mandatory choice. The reasoning is purely physiological. Most drugs are cleared by the kidneys, and if the kidneys fail, those drugs accumulate to dangerous levels. UFH bypasses that clearance problem entirely. You also rely on UFH for cases demanding rapid on and off reversal, like a massive pulmonary embolus or a patient heading straight into emergency cardiac surgery. The heparin class demands high maintenance through IV or subcutaneous access, but it buys you the granular, minute-by-minute control required for unstable or organ-compromised patients. That brings us to our final branch: stable embolic situations. This includes cases like a routine deep vein thrombosis or a stable pulmonary embolus. On this third branch, the rule is prescribing newer non-vitamin K oral anticoagulants, or NOACs, like apixaban. Highlighting this node reveals their massive benefit: rapid action. Contrasting directly with the Warfarin branch shows you eliminate the complex 5-day bridge entirely. But that convenience has a strict limitation. NOACs are completely contraindicated for the complex valvular or severe renal cases we just covered. NOACs are a highly effective modern tool, provided you rigorously restrict their use to structurally sound, physiologically stable patients. Even with perfect selection, plan for worst-case scenarios. If severe bleeding occurs and blood pressure drops rapidly, you need an immediate reversal agent. This matrix maps out your specific safety nets. For warfarin toxicity, you administer vitamin K. Note the operational caveat here: vitamin K works, but it is a slow-acting antidote. Dropping to the second row, if dealing with heparin toxicity, you must administer protamine. Finally, reversing the antiplatelets aspirin and clopidogrel requires a physical platelet transfusion. Memorizing these specific pairings forms your ultimate safety net, ensuring you are never caught without a strategy when a therapeutic dose turns toxic. Let's pull the clinical framework together into a unified view. Rule 1. Valvular disease mandates warfarin with a 5-day enoxaparin bridge. Rule 2. Failing kidneys or rapid reversal mandates unfractionated heparin. Associate urine failure with UFH. Rule 3. Stable embolic events get DOACs. Mastering this algorithm replaces pharmacological confusion with a definitive bedside protocol, helping you standardize care and mitigate risk in high-pressure environments.